This is Chapter 29, Part 3, continuing on talking about Type 1 diabetes mellitus. So with Type 1, with kids, we're still going to have them do those finger sticks to do the self-testing for their blood glucose levels, and we're going to try and keep those levels between 80 and 120. There are some newer technologies out there that don't require blood, where you can put a little probe on the skin that draws out some interstitial fluid, and it's able to calculate through that what the blood glucose is. That is not technology that's readily available or in use in this area at this time. So our mainstay is still those finger pricks, and along with those we need to do hemoglobin A1C levels. The finger stick gives you an exact amount at this moment, how much glucose is in the blood. The hemoglobin A1C tells you how much glucose that blood cell has been exposed to over its life. So it gives you an average of what the blood sugar's been doing for the last 2 or 3 months. This prevents kids from not being very good with their diet and insulin, and then the day they come in to the doctor's office being very good. So we can see how they've been doing over a 2 to 3 month period. Whoops. Nutrition. Kids who have type 1 diabetes, they need to have a consistent schedule of when they're eating and when they're doing their insulin, and that they need to have consistent carbohydrate intake, that they're not having, Skittles for lunch and very limited carbohydrates for dinner. I mean, it needs to be consistent. And remember, their nutritional needs are no different than other children. They still have the same caloric needs. They still need to grow. They still need to play. They're still regular children. Exercise is going to increase the cellular metabolism. It's going to increase the metabolic demand of the cells, so they're going to need more food before exercise. And kids are, they go to birthday parties, they have classroom parties, things like that. We don't want kids who have diabetes to be totally different than other kids. So we're still going to let them eat sugars and sweets in moderation. They're going to need to take extra insulin before they go and have that birthday cake. But we do want to, not encourage bad eating habits all the time, but let them have those special times when they do get treats, just like other kids. Exercise, we want to encourage exercise. It's good for all kids, including diabetic kids, but realize the cells are going to use more sugar in exercise, which means we're going to drop the blood sugar levels. So we want to make sure kids do have an extra snack before they go out and exercise. And exercise is a good thing. Often kids will have a decrease in their insulin requirements if they're exercising more frequently and regularly. Now, hypoglycemia, this is our most serious complication of diabetes. Hyperglycemia does a lot of damage slowly. Hypoglycemia will kill you quickly. So we really want to avoid hypoglycemic spells. Most of the time they're going to occur either before a meal or when the insulin has peak effect. And remember, some of our insulins, the peak, it may be 4 to 6 to 8 hours after it's taken. So we need to make sure that we realize that and the family realizes that, so they're really paying attention to during that peak time of the insulin, the child has had a meal, that they're not going without food during that peak effect. When there's a burst of physical activity and no additional food was taken before that, remember, we used it up. We raised the cellular metabolism and used up the sugar that was available. When a child has a hypoglycemic spell, we want to first give a simple carbohydrate, something that's going to be rapidly absorbed, and then we want to follow that with a complex carbohydrate and a protein, so that we have slower absorption of sugar. We don't want to have them drink some orange juice or eat a hard candy. shoot the blood sugar up real high. We still have all this insulin. It's going to drop back down. So we want to then follow it with a meal, a peanut butter and jelly sandwich or whatever that's going to have some protein, some complex carbohydrate, so we have some slow and continual absorption of carbohydrates, of sugar, through the gut into the bloodstream. If a child is not conscious, so they can't drink some juice, they can't take a piece of candy, we're going to need to give them glucagon. This is a injection. Usually they're the self-injecting pens, sort of like an EpiPen. Illness management. Kids with diabetes get sick just like other kids. It's much harder though to control their blood sugars when they're sick than when they're well. Even if they're ill, they're not eating well, they're still going to need insulin. The dosage is going to need to be adjusted, but being sick tends to raise the basal metabolic rate, so they still are going to need, the cellular need goes up. Our bodies do convert some of that stored glycogen into glucose, and it does more of that during illness, so often they'll actually be hyperglycemic during an illness. They may not be ingesting, eating very well, and depending on the kid, it's just going to take a lot closer monitoring. Are they high or are they low? And even if they're not eating, they could be high just because of that converting the glycogen stores into glucose, and they might then be low because they haven't ingested anything. So it needs to be very closely controlled. Even a minor illness can often land a child with diabetes in the hospital. If they are hyperglycemic during an illness, remember we talked about earlier how that contributes to dehydration. You're going to have increased urine output, and you're going to have fluid shifts, and that's going to cause cellular dehydration. So we need to make sure they're staying very well hydrated. They're going to require even more extra fluids than the average kid during illness. Diabetic ketoacidosis, DKA. I know you've talked about this a little bit with adults, and adults can do this sometimes. Kids do this frequently. So this is a frequent complication of type 1 diabetes mellitus. So the first thing we're going to do, if we have a kid admitted with DKA, and initial diagnosis, usually they come in at least some level of DKA, the very first thing we're going to do is hydrate and replace electrolytes. Unfortunately, I've seen many well-meaning family practice doctors give a nice dose of insulin because their blood sugar's high, and really their blood sugar's high because they're profoundly dehydrated. That is not the correct first reaction. First thing, we need to hydrate them, but we're going to be checking their electrolytes every couple of hours and changing their solution based on that. Remember, your heart does not like sudden changes in electrolytes, particularly in potassium. We said that when we're acidotic, we've got that extra hydrogen, which is a cation just like potassium, so that's going to cause us to have some potassium shifting. The profound dehydration is going to pull potassium out of the cells. So if you just give a big dose of regular insulin, you can get electrolyte shifting, particularly potassium, and you can have cardiac arrest. So if nothing else, if you go and work in an adult facility and you see a kid with diabetes mellitus come in, and the doctor wants to give a nice big dose of insulin, say, no, I'm not going to give that. We're going to call Children's Hospital first. If you get nothing else from this, please just do that. So treatment, first fluids and electrolyte replacement, and then we're going to start a low dose infusion of regular insulin Generally, it's a continuous IV infusion. And when we start that, usually we also start some sugar in the IV solution. And we're kind of adjusting the two to get an adequate blood sugar and continuing to rehydrate and monitor their electrolytes. Potassium's our big one we have to be careful with because the heart does not tolerate shifts in that. And we need to make sure the child's voiding, that they are dumping out some potassium in every void before we give potassium. So make sure they're voiding first before you add potassium into the IV. And remember, fluid resuscitation can't be done extremely fast. It needs to be done over, a day or so, day or two, depending on how dehydrated they are, because of the risk of cerebral edema. We said we've got dehydrated cells right now. If we rehydrate them too rapidly, we can cause cerebral edema and seizures, and if it's significant enough, we can do some permanent damage there. So how do we work with these kids? What's our implementation of care look like? Well, we want kids to do their own diabetic care as young as they can. By 4 to 5 years, they can assist with their blood glucose testing. And by 9 years, they can give their own insulin with supervision. We're going to have the parent or somebody else using the either the sliding scale based on the blood sugars or doing a count of their carbs that they're going to eat to determine how much insulin. But they can probably do their own shots. And in fact, I mean, 9 years old, that's 4th, 5th grade. I would say at Children's Hospital, I think they tend to have kids doing their own shots, maybe even a little younger than that. And here's a picture of a child doing his own glucose monitoring. And some of the nursing diagnoses that go along with diabetes mellitus, risk for injury, both related to insulin deficiency. And remember, if you have a lack of insulin, you're going to have too much sugar in the blood, so that would be hyperglycemia, that one would be talking about, and risk for injury related to hypoglycemia. And then, of course, when we have a new diabetic, knowledge deficit is that is primarily what they're at the hospital for, teaching. I mean, we do the initial rehydrating and electrolyte balance and getting their glucose level down to a good level, and then we keep them for several more days to do this teaching because they have so much they need to learn.